To move on to a very timely topic delivered by Dr. Vipula Bhattaduarachi, lecturer and specialist in respiratory medicine and the Deputy Director of the Respiratory Center, UCFM. From the Department of Pharmacology, Faculty of Medicine, University of Colombo. He is going to talk to us on this very timely topic about asthma, what is new. So I would like to invite my colleague to proceed. Over to you, Vipul.
Good afternoon. Thank you for your kind words. So I'll be talking to you in this brief presentation on some updates about asthma. So I will keep it very simple. So my aims are to explain to you why asthma management is rapidly evolving and some newly discovered mechanisms in asthma which helps in diagnosis and current management, and some new diagnostic entities based on the new discoveries, and new treatment and management strategies. And also the Sri Lankan context, how we can apply this in our setting, and also some points on future of asthma care. So asthma burden is quite high. It's about 300 million people worldwide. It's about like 1 in 27. But in asthma affluent areas, it's even more higher, like maybe 1 in 12 or 1 in 10. Asthma is sometimes underdiagnosed and sometimes misdiagnosed. About 5 to 10% of the patients are actually disease refractory and resistant to corticosteroid treatment. So this is the category which is really difficult, challenging, and important. And there is a substantial morbidity and annual healthcare expenditure, mostly due to this difficult category, actually. So what about the Sri Lankan status? Actually, we don't know because we don't have data. So just to recap very basics of asthma. So it's a chronic inflammatory disease affecting the conducting airways. The main primary pathologies in the bronchioles, which are not supported by cartilages. The innate and adaptive immune system act together and interact with the epithelial cells to produce pathological changes. So basically, it causes bronchial hyperactivity, that is due to various chemical mediators due to activation of the immune pathways. Then there is mucus overproduction due to goblet cell hyperplasia and even epithelial cell metaplasia. Uh, then airway wall remodeling, which happens due to various mediators like transferrin growth factor beta, amphoregulin, which causes permanent kind of changes. Then airway obstruction. We consider this as kind of in asthma reversible airway obstruction, but there is a category of patient now with fixed airway obstruction as well. So just what happens is when when the obstruction in the bronchioles, the patient can breathe in, but patient can't put the breath out. The collapsing point moves proximally, so there is air trapping. So patient feel chest tightness, and what happens is patients start breathing at a higher lung volume. So that is quite inefficient, and patient go into respiratory distress. So that is the basic mechanism. So patient usually get these cardinal symptoms: wheezing, chest tightness, and shortness of breath. And there is contribution from the diurnal variation, that is from the pituitary adrenal cortisol axis, which has some influence on the immune system. So these also contribute to variation in the symptoms. Then our traditional classification of asthma is basically allergic and non-allergic asthma. Allergic asthma usually start in the childhood and progress gradually. Usually start with like something like atopic eczema, then rhinitis to asthma. We call it atopic march. And also, although the pathology is quite clear cut in the bronchioles, the inflammation is actually throughout. So we call it now united airway disease. Uh, in contrast, the non-allergic asthma it's adult onset, usually occurs in females, obese, maybe with nasal polyps and chronic rhinosinusitis, and they are quite resistant to treatment. So that is the category which has some different pathophysiologic mechanisms. And also now we considered asthma as a syndrome rather than a disease confined to respiratory system. Uh, so currently we are now moving into the different endotypes that is based on different genetic and immune unique genetic and immune mechanisms. So eosinophilic asthma now usually considered as a disease manifested by T2 signals, T2 pathway, interleukin 4-5, and T2 helper cells. And now there are other mechanisms found to be contributing to that eosinophilic asthma. Then we have neutrophilic asthma, which is mainly contributed by this T helper 17 cells. Then we have Th9 subset mediated asthma. Then we have other several types, but I have not included all here, and we have not found. We are still investigating other endotypes, postgranulocytic, and there are other overlapping endotypes as well. So just to not to complicate, just to show you some of the important mediators. Now T helper cells, T2 are the key cells in eosinophilic asthma. And now actually earlier it was considered T1 is not suppressed in asthma or inhibiting, but now there are evidence that T1 also contributing to asthma at different time points, and also T9 and T17, as I mentioned earlier, and also T regulatory cells. Regulatory cell failure has been identified as a mechanism of asthma, the imbalance of the immune pathways. Then the cell types like macrophages, dendritic cells, and epithelial cells. Uh, Especially dendritic cells and epithelial cells found to be interact very specifically with certain antigens like fungal and also with certain viruses. So there are specific pathways activated by these antigen and epithelial interactions, which leading to actually resistant type of asthma and also endotype switching. Then we have this innate lymphocytic cells, which I mentioned earlier. These are actually classified earlier as non-T or non-B cells, and these cells also can activate eosinophilic pathway. So, but we don't know the relative contributions from T helper and innate lymphocytic cells. But this is important with certain antigens and found to be important contributor in eosinophilic asthma. Then we have other cell type, eosinophils, neutrophils, basophils, mast cells. Sorry about this. Then various interleukins, interleukin 4-5, uh, contributing to T2 asthma, but now we have found other very important interleukins like 9, 13, and 17, and also thymic stromal lymphoprotein. These are significantly contributing to certain fueling certain immune pathways. Uh, there are many other, but I have included the important ones. Then we have this important IgE and IgG1. IgE usually increased in allergic asthma, which is a hallmark of T2 activation. Just to show you these cell types, epithelial cells, dendritic cells, and innate lymphocytic cells. Uh, Actually, those are the kind of starting points in these complex pathways. Just to touch something about asthma comorbidities, which we sometimes not pay much attention. Now, breathing pattern disorders is a quite a common association with asthma symptoms. Sometimes these are asthma symptoms are aggravated by breathing pattern disorders, or sometimes patient present I mean, completely due to breathing pattern abnormalities. Then upper airway disease, uh, like rhinosinusitis. If we don't treat upper airway disease, sometimes asthma tend to be like persistent with symptoms. Then gastric reflux disease, especially in obese people with upper GI dysfunction. Then underlying psychological background like anxiety, depression can significantly contribute. Then obesity and obstructive sleep apnea. Uh, so it is very important to screen these comorbidities objectively. So we have different screening tools. Unfortunately, these are not validated to our local language. For example, gastric reflux, we have GERD Q questionnaire. Then anxiety, depression, HADS. Obesity, we can measure BMI and monitor. OSA, we have Epworth scale. Upper airway disease, we have SNOT 22. And breathing pattern disorders, we have Nijmegen score. So these are very important aspects in asthma management, especially during initial encounter. Then few biomarkers, especially for eosinophilic asthma. Eosinophilic count, FeNO, which is fractional expiratory nitric oxide, which indicate eosinophilic airway inflammation, and IgE. These are quite helpful to monitor eosinophilic asthma, especially with advanced treatment. Then we have periostin, which is quite specific but not very popular in the clinical setting. It's a biomarker for type 2 mediated eosinophilic inflammation. Uh, then something about screening and monitoring, which we do not pay much attention during our normal clinic follow-ups. Symptom diary and peak flow diary quite important, especially to monitor patients and also when the diagnosis is not very conclusive. Then ACQ6 questionnaire, which is very helpful to monitor symptom burden and the asthma status in clinic setting. Then spirometry with reversibility, which is important in the diagnosis as well as in monitoring. We do not use spirometry usually in the monitoring because of the lack of availability, but it's quite helpful. Then FeNO for eosinophilic asthma. It's very helpful. Now we have uh, portable devices, so it's very helpful in clinic setting to monitor. Then other relevant investigations. So this set of investigations are very helpful. Then just to touch very basics of treatment. Now in asthma, we have ongoing inflammation and the treatment basis is to suppress inflammation. Then we have exacerbations and the principle is to dilate airways. When we dilate airways, all those pathological changes will reverse. Then the prevention of future episodes, the key to that is avoidance of allergens. It's very important to identify for what allergens patient is sensitive and avoid them. Actually, most of the exacerbations are caused by viruses like rhinovirus. It's difficult to avoid, but it's the principle here. So just to touch some basic medicines, we have two traditional bronchodilators or relievers, that is to which cause bronchodilation, and preventers, which are anti-inflammatory agents, which suppress inflammation. And just to show, recap some of the medicinal classes, we have beta-2 agonist, short-acting and long-acting, then antimuscarinic, short-acting and long-acting. Then those are the key medicines, bronchodilators. Then we have leukotriene receptor antagonist. This cysteine leukotriene 1 receptor is very important receptor, but leukotriene receptor antagonists and methyl xanthines are kind of second line medicines. Then we have anti-inflammatory medicines. Steroids are the cornerstone in management. Then some contribution from mast cell stabilizers and leukotriene receptor antagonists, which also have some anti-inflammatory effects. So I have already described some of the why this unique pathophysiology and endotypes, and why it is syndrome rather than isolated disease, these comorbidities, then overlapping conditions and comorbidities. Then I will touch on these areas like personalized care plan, multidisciplinary management, in social support network, and how to follow up and advanced treatment options available. Now, this is a basic plan of asthma management, but always it is individualized thing. This is GINA guideline. So the principle is, with increasing severity, we step up the treatment. So we have these two options now. Uh, the option two is our typical management pathway with two inhalers, short-acting beta agonist and steroids. Uh, now the one is the combined inhaler smart regime, which I will describe in subsequent slide. So if the symptom burden is high, we can increase the uh, beta agonists or relievers. If the exacerbation frequency is high, we can step up steroids, or we can increase based on the individual patient's condition. The other option is to add on second line medicines like theophylline or mast cell stabilizers. With each step, it is very important to go through assessment, adjustment, assess, adjust, and review response. So those are the very basic steps that we should follow. So problems happen when we move on to the last category, that is step 5. That is where we face problems. So that is where this 5 to 10% treatment resistant patient fall into. So just to give you some idea about smart regime, that is single maintenance and reliever therapy. This is very simple application. Here, what we do is we use a combined inhaler with a long-acting beta-2 agonist and a potent steroid. What we do is we ask the patient to take the regular doses as usual, and also to take the same inhaler as the reliever to relieve symptoms. So patient is using a single inhaler, and actually that improve the compliance, and also it's a quite very effective type of regime. So actually we can't use all type of medicines in this regime. These are two examples: budesonide and formoterol combination, and also mometasone and formoterol combination. As I mentioned earlier, it improves compliance and effective and very convenient to the patient. Why we use these medicines? Because formoterol has a rapid onset of action and long action. Because of the rapid onset, we can use it as a symptom reliever. And we always use formoterol in combination with steroid. Then fluticasone is a potent steroid, and it is used in this regime. These are some of the tips based on some evidence, but I have not, just to give some practical uh, uh, insights. Now, when the patient start the exacerbation, it is very important to start steroid as early as possible, because once the inflammatory pathways are active, it will go on and on. So, when the first symptom appear, patient should start ideally with steroids. Then, if the symptoms are quite severe and persist longer, we should adjust the steroid short course of steroids. We can increase the dose and we can gradually tail off. That depends on the patient's factors and also what has caused the exacerbation. Some viruses can cause post-viral hypersensitivity, quite longer duration, maybe several weeks. Then increasing the strength and frequency of the short-acting beta agonist puff during the exacerbation also very helpful to control symptoms, especially when use them quite early while coming to the hospital. Then vaccination of the vulnerable groups. This is something we do not practice in our setting. We don't have a vaccine for most of the viruses, but uh, influenza virus and influenza vaccine, and we have vaccine for respiratory syncytial virus, which may not available here, but vaccination of the severe patients and also patients with other comorbidities are quite helpful. Then very important to check the inhaler technique in each clinic visit, and also to check the compliance. So that is a recommendation, although we do not practice that. Then these are some of the new generation medicines available, which may not available in our setting. SABA, the albuterol and levobuterol. Then we have indacaterol, oxytropium, short-acting muscarinic agonist. Then long-acting muscarinic agonist, we have actinium, umeclidinium, which are quite useful in with inhalers. These are used in COPD, but some are not approved in asthma. But in other countries, they use off-label quite effectively. Then some of the advanced treatment, uh, we have the top five is currently in use. Omalizumab, dupilumab, prasulizumab, mepolizumab, and benralizumab, which are targeting this eosinophilic pathway, interleukin 4/5, and also allergic asthma, IgE. As I showed you in the previous slides, now the bottom three, interleukin 17, 13, and 9 antibodies also in trials for some of the uh, endotypes. The problems with maps are the unavailability, which are not available in our setting, and also uh, they are subcutaneous or IV. Now there are self-injectable preparations, and they are quite expensive. One injection is like hundreds of pounds, so maybe not accessible to us even in near future. And some of the patents are also not expired yet. And other problem is they need this treatment needs long-term treatment, like 3 weekly, 4 weekly injections. So it's a very costly kind of business. Uh, and other thing, it's only for a very selected category of patients. Very important to select the patients very carefully. Otherwise, they will either they will not respond, or it will be just a kind of waste. Uh, then other thing is adverse effects. Actually, we don't know the full adverse effect profile of these antibodies. Then some of the strategies in new kind of in asthma management. We have now triple inhalers, which are again not available in our setting. The only good thing is that improves the compliance when the patient needs three combinations. Then compliance detection using these link devices, inhaler devices linked to digitally linked to a mobile app, and data is recorded, so we can easily access to compliance. Especially when we make decisions on advanced treatment, we have to confidently assess the compliance. Then there are other mobile apps which we can communicate with the patient, uh, health education, and various other health related communications. Then artificial intelligence for data handling to identify various patterns and various sub cohorts and different type of patients, different subsets. Very important, very helpful in managing when we categorize that type of cohorts. So other countries, they use artificial intelligence for that type of data handling. Then regional and national registries to better isolate cohorts for the same reason. We don't have such system. So it is very important to have that type of systematic data when we have this manage this type of chronic diseases. Then unexplored areas, one is susceptibility to viral infections. Some patients are very susceptible and they get recurrent exacerbations despite whatever the treatment. Then this regulated T cell failure, which is unexplored area, how this imbalance goes on like T1, T2, then sync and also switching, then single nucleotide polymorphisms, which are important in this antigen anti interactions, disease manifestations, prognosis, and treatment response, and many aspects. Then identification of these key immune checkpoints that will helpful to identify therapeutic targets. Then actually the low cost other options uh, to manage uh, asthma patients successfully. In our context, what are the important things? Actually, sometimes we don't diagnose asthma patients properly. For example, sometimes this pediatric category, we categorize them as asthma just because of few episodes of viral, post-viral hypersensitivity. In the other end, sometimes we categorize heart failure or patients with breathlessness just by giving an inhaler as asthma. Then we could manage as asthma. So that is not the proper way to diagnose. We have to objectively diagnose asthma patients. Then treatment of comorbidities also not we do not focus. Then diagnostic difficulty with eosinophilia in our country and tropical countries. That is because of the parasitic diseases. At one end we have this eosinophilic lung diseases, other end we have these parasitic diseases. So it is important to exclude parasitic diseases before diagnosing uh, eosinophilic asthma. So it's a kind of a challenging scenario. Then time limitation and funding issues in our setting. Practically what we can do is we can decentralize care to primary whatever the facilities available, and to use other healthcare professionals like nurses and physiotherapists, and use of technology, IT based technology for data handling and clinic follow-ups and keeping records. Then we don't have data for epidemiology, as I mentioned earlier. To have proper epidemiology data, we should diagnose the patient properly and follow up. So we should have a structured system to manage asthma properly. We don't have much pharmacological treatment, but uh, then just to highlight, not do not label just because of patient having wheezing and say, episodes of wheezing, and we need diagnose objectively with spirometry and reversibility and with other investigations. It is important to use these simple things like symptom diaries and peak flow diaries, uh, yeah, spirometry and reversibility for diagnosis and monitoring. Then correct assessment of the severity and comorbidities, as I mentioned earlier, with screening tools. Then screening chest X-ray to exclude the other lung pathology, especially in our setting. Very important to exclude tuberculosis, at least in the during the first encounter to have a chest X-ray to exclude anything presenting as asthma. Then use of ACQ questionnaire to monitor asthma control is also quite useful. Then use of Pheno in eosinophilic asthma. It's a portable device which we can use to monitor the treatment response. When we have a objective kind of monitoring, we can better adjust the treatment. And systematic approach and proper record keeping will helpful to achieve these targets, and multidisciplinary involvement in asthma. We don't do much multidisciplinary involvement, but it is very helpful. Nutritionist, physiotherapist, gastroenterologist, psychiatrist can helpful to in management of these comorbidities. Then personalized care plans, which are based on the patient's requirement. We can individualized patients care plan. That is the current recommendation. Then community-based and home-based approach. We have now home-based devices and communication method, so that will reduce the burden from our secondary, primary, tertiary care setting. Then data capturing and maintaining, we should have some system. Then to have specialized clinic to manage difficult asthma patient. It's very important to categorize and manage difficult asthma patient in a specialized setting. Then we can pay much better attention to them and diagnose, treat, and follow them up as a special cohort. And there are individual variation within this difficult asthma patients as well. So that is the conclusion. You can ask a question.
Thank you very much, Vipula, for that very comprehensive lecture. I'm sure there are questions from the audience.
Thank you for that update. I have two questions. One is, so now is there no place at all for oral medications over longer areas?
Actually, so theophylline we use this, but oral salbutamol is not currently used because of the side effects profile and things. But still, I mean, in our setting, people are using oral salbutamol, but as for the current recommendation, it is not recommended. Inhalers are the kind of first-line treatments. But theophylline, of course, we use. Even aminophylline is used in severe asthma, I mean acute severe asthma. Yeah, even in UK they are recommended.
So there is different for hospital, they say cause tachycardia and palpitations.
Yes, the problem is the availability. Actually, these new generation medicines are quite safe. I mean, side effect profile is quite less, and they are quite specific, and their molecular characteristic also much better, and with the better delivery to the distal airway. Problem is the cost and lack of availability.
I mean, when it's oral hospital, there are claims that it's produced tachycardia or.
Actually, that I'm not very sure.
The second question is, I mean, it's going out of the area that you actually wanted to cover in the lecture. I just feel that there's a big element of airway pollution or environmental pollution in our asthmatic, especially in Colombo.
Yes,
now. I mean, I know we intend to cover that in the lecture, but it's a big problem because no matter what you use, you can't escape.
Yes, especially these microplastics and things now coming to the picture, which goes kind of exacerbate many lung diseases, not only asthma, and contributing to many lung diseases. Yes, so that's some actually irritants, some are probably allergens.
Thank you very much, Vipula. In the absence of any questions, we would like to conclude and thank you. And please accept the certificate of appreciation. Vipula.